patients, not all persons with one or more abnormalities in this test actually have liver disease. So everybody reporting with deranged LFTs does not mean that the patient has liver disease. So the liver function test commonly includes bilirubin, ALT, AST, gamma GT, alkaline phosphatase, we all know. But albumin and PT-INR is also part of liver function test panel, although we have to mark it separately. So when faced with an abnormality in a clinic or in a ward in an asymptomatic patient, it is imperative to establish that there is an abnormality in the first place. Because sometimes there are physiological conditions in which that LFTs becomes abnormal. Like in adolescence, the alkaline phosphatase is raised. In pregnancy, the alkaline phosphatase is raised. So those are physiological causes. The test should be repeated when confirmed and appropriate steps be taken. So the clinical situation where LFTs are most helpful is differential diagnosis of jaundice, detection of hepatic dysfunction in the non-jaundice patient, rough measure of the degree of hepatic dysfunction in a patient with known liver disease, assessment of the progression of known hepatic illness under serial observation. Like we do it in liver disease patient, which regularly follows up in the clinic. We do serial intermittent LFTs to see whether the liver function test is worsening or not. So detailed history and full examination is the key, and there is no shortcut in that. Drug intake, Hakimi meds, herbal medications, we need to rule out because this is very common in this part of the world. And we have to rule out whether the patient is taking a Hakimi or herbal medication. These medications are available over the counter. Risk factor of viral hepatitis, alcohol consumption, so the good history will give you key. Diabetes, obesity, and hyperlipidemia to rule out NAFLD because after hepatitis B, C, and alcohol, this is the leading cause. NAFLD is the leading cause of deranged LFTs and liver failure. Family history for Wilson's disease, hemochromatosis, and autoimmune disease. Occupational exposures to toxin, whether that person works in a factory or in a company or with chemicals that can affect liver. So we'll go each component one by one. So bilirubin, we all know, is formed from the lysis of the red cells within the reticular endothelial system. And we have two types of bilirubin, unconjugated and conjugated. Unconjugated is transported to the liver loosely bound to albumin. It is water insoluble and therefore cannot be excreted in urine, whereas conjugated bilirubin is water soluble and appears in urine. So this is the diagram which shows the physiology of and circulation of the bilirubin. And you have already studied this, and you know that the conjugated bilirubin is, the unconjugated bilirubin cannot be excreted in the urine, whereas after conjugation, the bilirubin is excreted in urine. And a part of the bilirubin is also excreted into the feces. So what is the causes of isolated hyperbilirubinemia? And then we talk about it. We divide into two, unconjugated and conjugated. Most of the causes are because of raised unconjugated bilirubin, in which there is ineffective hemolysis, erythropoiesis. So if there is bilirubin increase, you have to think of hematological disorders as well. Blood transfusion, if the person has received more than 4 blood transfusion in a single day, then it can cause increased bilirubin. Then decreased hepatic intake, which is Gilbert syndrome. There are various medication, rifampicin. Then there is curricular Najjar syndrome. And there is physiological jaundice of newborn, in which again unconjugated bilirubin is increased. Then there are two causes of conjugated bilirubin which is increased, which is Dubin-Johnson syndrome and Rotor syndrome. So it is worth mentioning here that bilirubin levels of more than 5 milligram per deciliter in the presence of normal hepatic function cannot be explained solely by chronic hemolysis alone. So if the patient has more than 5 bilirubin level, we need to have some sort of liver dysfunction as well. Bilirubin levels have prognostic significance in alcoholic hepatitis, primary biliary cirrhosis, and acute liver failure. Conjugated bilirubin is excreted in urine, and bilirubin level rarely exceeds 30 milligram per deciliter in the absence of renal failure or hemolysis. So if the conjugated bilirubin or if the bilirubin level is more than 30 milligram per deciliter, so if the patient has normal renal failure, the level should not rise more than 30. If the level rises more than 30, that means that now the renal is at fault, the kidney is at fault, and it's not functioning properly. What about aminotransferase? These include AST and ALT, and they are an excellent marker of hepatocellular injury. Whenever we talk about hepatitis, means inflammation, means we are talking about SGPT and SGO. So AST is found in liver, cardiac muscle, skeletal muscle. Again, it is not specific to liver, and it is found in many organs in our body: kidneys, pancreas, lungs, red cells. ELT is cytosolic enzyme, is found in its highest concentration in the liver, and it's more specific in liver as compared to AST. Hepatocellular injury and not necessarily cell death is a trigger for release of these enzymes. The first step should be to assess the degree of abnormality. So definitions of mild, moderate, or marked elevation of liver enzyme. When we talk about mild, we are talking about less than 3 times upper limit normal of ALT, less than 2 times upper limit normal of alkaline phosphatase, and less than 3 times upper limit normal of gamma G. When we talk about moderate elevation, we talk about from 3 times to 20 times elevation of ALT or AST, twice to 5 times elevated alkaline phosphatase, and thrice to 10 times elevation in gamma G. And marked elevation means more than 20 times of alkaline phosphatase, more than 5 times of alkaline phosphatase, sorry, more than 20 times of AST, ALT, and more than 10 times of gamma G. So what are the common causes of raised transaminases? Common is alcohol. Then there is chronic hepatitis B, C. There is drug induced, which is lipid lowering drugs, anti-epileptic, anti-tuberculous drug, anti-inflammatory drug. Then there is non-alcoholic fatty liver disease, which is very common in this part of world because of diabetes, obesity. Autoimmune diseases, hemochromatosis, Wilson's disease, congestive cardiac failure. Sometimes celiac disease also give rise to mild elevation in aminotransferases. And there's glycogen storage disease. So when you encounter a patient with elevated liver disease, history and examination is important, and then you have to first screen out these patients with viral serology because this is the most common cause in this part of the world. Then according to symptoms and signs of liver disease, you have to do further evaluation of these patients. And if you think that the patient has genetic disease like hemochromatosis or Wilson's disease, then you have to do workup by doing specific tests, and sometimes liver biopsy is also indicated. And if you think that the patient is obese, patient is diabetic, then you have to think in terms of nephral disease, and then you also inquire about the drug intake history, basically. And then sometimes you have to observe if there is more mild elevation in LFTs, and then you need to repeat serial LFTs. So just give me a second. So this is the general pattern of liver biochemical values according to type of liver disease. If we talk about hepatocellular necrosis, the etiology, if we talk about etiology, it's ischemia, viral hepatitis, alcohol. And for toxin and ischemia, the common cause of toxin is acetaminophen, which is Panadol or paracetamol poisoning, and in which the aminotransferases is way too high. Alkaline phosphatase is slightly raised. Bilirubin is slightly raised. There is prolonged and unresponsive to vitamin K in severe disease, the PT. And albumin is decreased in subacute and chronic disease, because we know that the half-life of albumin is 21 days. So albumin does not increase in acute injury. While hepatitis A and B is common, sometimes there is atypical viral injury. Like these days, we are seeing corona, and this is very common. And we are seeing deranged LFTs because of corona. And again, in viral hepatitis, the aminotransferases are elevated, but not to that extent as compared to ischemic hepatitis. And then there's again mild derangement in alkaline phosphatase, and uh, bilirubin will be more increased as compared to ischemia. Then in alcohol, there is mild ALT increase. Alkaline phosphatase will be increased more as compared to ischemia and viral hepatitis, and so is the bilirubin. When we talk about biliary obstruction, we talk about complete and partial. Complete is pancreatic carcinoma. Partial is generally because of hilar tumor, primary sclerosing cholangitis, in which, as there is no hepatitis, so ALT will be mildly increased, but alkaline phosphatase will be way too high. And bilirubin will also be high, but more so in complete biliary obstruction. The PT will be prolonged, but it will be responsive to vitamin A, because there is obstruction. So fat soluble vitamin, which includes vitamin K, it gets decreased absorption in terms the PT increases. So if you give vitamin K, the PT will be responsive. And albumin will be usually normal until there is cirrhosis. When we talk about hepatic infiltrative disease, we talk about primary or metastatic carcinoma, tuberculosis, sarcoidosis, and amyloidosis, and in which there is mildly increased ALT, the alkaline phosphatase will be increased, bilirubin will be mildly increased, or they will be normal. The PT and albumin usually will be normal, unless if there is cachectic malnutrition in tuberculosis, then the albumin will be lower. Alkaline phosphatase originates mainly two sources, liver and bone. The enzyme may be present in a variety of other tissues, intestine, kidney, placenta, and leukocytes. The elevation may be physiological or pathological. Physiological, I already told you, in pregnancy because it released from placenta, in adolescent, in teenage because they are growing, so it comes from the bone. So common causes of raised physiological, adolescence, pregnancy, sometimes it's familial. Pathological bile duct obstruction, whenever you see raised alkaline phosphatase, you need to rule out biliary obstruction, primary biliary cirrhosis, primary sclerosing cholangitis, then there is drug-induced metastatic liver disease, bone disease. So clearly the first step in determining the cause is to identify the source of raised alkaline phosphatase. A good discriminator is testing for 5-nucleotidase of gamma GT, which is rise in liver but not in bone disease. So if you find alkaline phosphatase is raised, at once you need to see the gamma GT. If the gamma GT is normal, that means it is coming from the liver. But if the gamma GT is also increased, that means it is coming from, if the gamma GT is normal, it is coming from the bone. If the gamma GT is increased, it is coming from the liver. Because in bone, gamma GT is normal. And you need to get an ultrasound abdomen done to rule out biliary obstruction. So this is an algorithm. If you encounter raised ALP, at once you have to see gamma GT increased. If it's not increased, you have to rule out other non-hepatic causes. If it's increased, you have to get an ultrasound abdomen. You have to see bile duct obstruction. If there's bile duct obstruction, you proceed with ERCP. If there's no bile duct obstruction, you need to rule out primary biliary cirrhosis. You need to get anti-mitochondrial antibody, and you need to consider liver biopsy. If there is liver mass, you need to get further investigation, CT scan, and biopsy of the liver mass. So gamma GT is enzyme in hepatocytes and biliary epithelial cells. Though is a sensitive test for hepatobiliary disease, its usefulness is limited by lack of specificity. And sometimes it is also raised in pancreatic disease, myocardial infarction, renal failure, and COPD. So causes of gamma GT is hepatobiliary disease, pancreatic disease, alcoholism, chronic obstructive pulmonary disease, renal failure, diabetes, myocardial infarction, and drug-induced. So then we come to albumin. Albumin synthesis is an important function of the liver. Approximately 10 gram is synthesized and secreted daily. So with progressive liver disease, serum albumin fall, reflecting decreased synthesis. So in patients with chronic liver disease, we always do albumin. It is part of a Child-Pugh scoring to find out the severity of disease. And we all often found that albumin is way too low in these patients. And we do give sometimes IV albumin, and we do give oral supplements for albumin. So PT, the synthesis of coagulation factor except factor 8 is an important function of the liver. The PT measures the rate of conversion of prothrombin to thrombin and thus reflects a vital synthetic function of the liver. PT may therefore be prolonged in vitamin K deficiency, warfarin therapy, liver disease, and consumptive coagulopathy. So this is the hepatitis B. We've talked about liver interpretation of liver function test, and this in one slide, I would like to talk about interpretation of LFTs. When we talk about interpretation of LFTs, we talk about hepatitis B surface antigen, hepatitis B core antibody, hepatitis B core antibody IgM, this is IgG, and surface antibody. So hepatitis, if we talk about susceptible to hepatitis B surface infection, or if there is no infection, all the hepatitis serology will be negative. If the patient has hepatitis B surface antibody positive and core total positive, this means this patient had exposure of hepatitis B in the past and is now immune to hepatitis B. When we talk about vaccination, only hepatitis B surface antibody will be positive. When we talk about past infection, the hepatitis B surface antibody and core total will be present. So if the patient comes with hepatitis B surface antibody, you have to check core antibody and of course B surface antigen. If the core antibody is negative, that means the patient had vaccination. If the patient is immune because of natural hepatitis B infection in the past, then the patient will have core antibody. In the patient who has never exposed, never vaccinated, all the antibodies will be negative. In acute hepatitis B, the hepatitis B surface antigen will be positive. The total core will be positive. Sometimes it becomes negative also because it takes few weeks. But IgM will be positive. You know, IgM is an acute marker. So IgM and hepatitis B surface antigen will always be positive. But core will be positive sometimes, sometimes not. In chronic hepatitis B infection, the hepatitis B surface antigen and core total will be positive. So core is a chronic infection. So in acute, sometimes if you have checked core in the acute very early phase, it might become negative because it takes 2 to 4 weeks to develop. So only the core is positive and other antibodies are negative, which means that the resolved infection, false positive hepatitis B core total, susceptible, low level of chronic infection, resolving acute infection. That means that the patient does not have developed antibodies, and you need to vaccinate these patients basically because they still can get hepatitis B in future. So when to refer for a specialist opinion? Every derangement does not mean you need to refer to a gastroenterologist. And sometimes the general physician, the internist, the family physician can manage these patients. If there is unexplained liver abnormalities more than 1.5 times normal on two occasions, a minimum of 6 months apart, then you need to refer to a specialist. Unexplained liver disease with evidence of hepatic dysfunction like low albumin, increased bilirubin level, prolonged PT or INR. This means that the patient is going into chronic liver disease. Known liver disease where treatment beyond the withdrawal of the implicating agent is required. If you know that this is drug induced and you have stopped that drug, but still the liver function is not getting better or it's worsening, then this is the time that you need a specialist referral. So what is the take-home message? Liver tests often become abnormal in non-hepatic disease. So all liver function test does not mean that the patient has liver disease. This is a very important point which I need to make. If a systemic approach is adopted, the cause is often apparent. So you need to take a good physical examination, a good history, because often the clue lies in the history taking. A good clinical history and physical examination are often rewarding. Abnormal liver function test may present in an asymptomatic patient. A specialist opinion should be sought when appropriate. So this is quiz. 40-year-old male, previously healthy, presented with low-grade fever, vomiting, and nausea and anorexia for 1 week. So it's a short history. No PSC or no history of chronic liver disease. So it's acute disease. On examination, there is jaundice, but he's not pale. The chest, CVS, and abdominal examination is unremarkable. Abdomen showed mild tenderness and right hypochondria. The lab abnormality showed that the SGPT is way too high. It is 2,500 international units with increase in total bilirubin, whereas the PT CBC is normal. The gamma GT is also almost normal, slightly increased. Alkaline phosphatase is normal, and ultrasound abdomen is also normal. So if you see here, basically the primary component which is increased is SGPT with slight derangement in bilirubin level. So the patient is having liver injury, inflammation of the liver, itis, which means hepatitis. And as I've said, it's acute. So the patient is having, short history is having acute hepatitis. Then you have to do viral serology, hepatitis B, hepatitis C, hepatitis A, hepatitis E. And if those are normal, then you have to think whether it's drug induced, whether it started any drug, or you have to poke further into the history for any substance abuse or anything like that. Another quiz, 60 years old lady, diabetic and obese, came with fever, right hypochondrial pain for 2 weeks. On examination, tenderness and right hypochondrium. The hemoglobin is 12, WBC is slightly high, 15, platelets through 14, PT is also borderline high. Bilirubin is high, SGPT is normal in this case, gamma GT is high, but in this case, alkaline phosphatase is high as compared to other components. The ultrasound showed gallbladder stones and CBD is prominent. So in this case, as I've already told you, that alkaline phosphatase when it's high, you need to think of biliary obstruction. So you at once, when the alkaline phosphatase is high, you at once see the gamma GT, whether the gamma GT is normal or not. In this case, the gamma GT is not normal. If the gamma GT is normal, then you might think of bone causes or any other causes. But in this, gamma GT is also high and the bilirubin is also high. So there is some problem in the liver and you need to rule out the biliary obstruction. In this case, likely cause of biliary obstruction is gallbladder stones because on ultrasound, the CBD is prominent. There might be some small stone which is not picked by ultrasound, and then you have to move on to other tests like MRCP, which gives you clue regarding there is stone or not in the CBD. And if there is stone in the CBD, you need to perform ERCP in this case. So this was the case of biliary obstruction. Thank you very much.